I spent a few hours in China since this morning. I feel really a great emotion. And so I want to thank all the China's friends, particularly Professor Hu, who gave me this opportunity, because it's the first time I'm here, and I would like to open a discussion with you, open a job with you, because I think we have to do all our best in order to try to make simple what simple is not. I mean, the CTO treatment. And that's the reason why I did all my best in order to discover new technique against a few dogmas, because when I started doing the so-called contrast modulation, I had a lot of skepticism around me. But step by step, people start using my technique. So now I'm no more a human being, I am a technique. I'm Carlino Technique, no more Mauro Carlino. But this other step, which is the HDR technique that in short time I will share with you, it's a technique that, in my opinion, can simplify this very difficult setting of so difficult lesions such as the CTO. And I'm very happy to share with you and with my Chinese friend, because I think that progress and innovation in China run faster than in the other countries. And so thank you for giving me this opportunity. Well, let's start with the presentation. Thank you very much. So, well, as I said, I want to share with you this HydroDynamic contrast recanalization, which is a new antegrade and intraplaque crossing technique for CTOs. And this is the last stop of a long journey that I started in the early 2000s, when I start talking about the contrast modulation of the plaque. And I like to draw in a parallel with the human evolution stages. And this is the contrast modulation evolution stage, which started with the peripheral star and continue with the coronary star, which was described by my mentor, which is Antonio Colombo. But this is not a contrast modulated phase. It was something that prepared the field of the contrast modulation treatment, because the first paper that for sure described this technique was the contrast guided star that they published in 2008, which was a rude technique, I know, but gave it to the operator the confidence of working in the extra plaque space. Don't forget that in that period, to be in the extra plaque space was considered a complication. And so it was not easy to describe a technique where I inject the contrast in that area. Then I published in the same year another interesting technique, which is the microchannel technique. In 2016, we published a paper describing the so-called Carlino technique. And now, a few weeks ago, was published this paper about the hemodynamic contrast recanalization, HDR, the acronym. And probably with you, I'm going to do something new for the future, because you are open-minded, and so together we have to write other pages of this wonderful book. Well, this is the paper, and for who is interested in this topic, I suggest to reading, because there is a well description of this technique. Basically, the hydrodynamic contrast recanalization is a novel technique to enable primary intraplaque, and I underline intraplaque, wire crossing during CTO PCI. HDR utilizes intraplaque contrast delivery through a microinjection to modify the plaque before passage of the polymer jacket wires. I think that the knowledge of the anatomy and the histopathology of an occlusive plaque in a CTO may explain why this maneuver can be effective. Well, this is a histological specimen of a CTO. You can see island of calcium intermingled with the soft part of the plaque. And this, again, is a three-dimensional microcomputed tomography of a CTO, showing, again, patchy fibrocalcific content, which is the hard plaque, intermingled with loose tissue segment, which are the soft part of the plaque. Well, suppose hydraulic forces are applied through a solid occlusion by a soft injection delivering a small contrast volume, which is exactly what you can see in this movie. In that case, the contrast will follow the path of least resistance represented by the loose tissue segment in the occlusion. This maneuver is aimed at recruiting the soft part of the plaque. That's the reason why you have to perform through a very soft injection. That's a crucial point. Because if you increase the amount of contrast or you perform a strong injection, areas of high resistance inside the plaque will divert hydraulic forces to a radial direction, as you can see in this movie, involving the extra plaque space, which is usually softer than the intraluminal obstructing material and lead to contrast extravasation. How to do this intraplaque contrast delivery? The injection should be very gentle. The amount of contrast is very low, less than 0.5 milliliter, and this is the appearance you can get after this micro injection. Because if you and more, the tip injection should be performed in a controlled manner under fluoroscopic guidance. This approach enables tailoring the amount of contrast delivered along with the force of injection to each case, as this parameter depend on the anatomic characteristic of the occlusive plaque, and these are different in different patients. Well, this is the correct injection. Look at what happens if I do a strong injection. You can see here there's an involvement of the soft part of the plaque, while if I inject strongly, there is an uncontrolled propagation of this section due to a powerful injection and creating a big hydraulic dissection. Well, here the description of the technique. Basically, you have to use a microcatheter with a floppy wire or workhorse wire, which is advanced to a site of the occlusion, abutting the proximal cap. The floppy wire then is exchanged for a dedicated CTO guide wire, according to the confidence with the different operator. I usually use the Gaia, but also Conquest or Miracle family guide wire are good. The proximal fibrous cap is penetrated centrally with the dedicated CTO wire for only a few millimeters, while the microcatheter is advanced into the proximal portion of the occlusion. The wire is simultaneously removed, and less than 0.5 milliliter of undiluted contrast using a 2.5 milliliter syringe is gently delivered via the microcatheter while taking cine images on the occluded segment. I think that this is the verbal description, but I prefer to show you this movie. You can see here the guide wire perforating the proximal cap. Then while I pull back the wire, I advance the microcatheter, and this is the slow. And I asked to the designer creating this movie to do a very slow injection. Why? Because I want to recruit the soft part of the plaque, modifying the plaque, and that's the reason why this guide wire goes easily inside the plaque. Basically, I create a favorable situation for the wire. Makes sense, this movie, no? Well, There are several possible outcomes after the intraplaque contrast delivery. First option, it's impossible to inject contrast due to high resistance. That means that again, inside the proximal cap. In those cases, we advance the guide wire 2-3 millimeter further into the occlusion and repeat contrast delivery through a microinjection. Second option, I described two different patterns of distribution after delivery of contrast inside the plaque. This is the pattern I call number one, which is a localized blush of contrast with a patchy distribution inside the occluded segment. You can see here very clearly. Basically, you can see the white part of this picture is formed by the island of calcium, while the contrast basically recruit the soft part of the plaque, and this explains why we can see this patchy distribution of the contrast. We hypothesize that a patchy stain denotes infiltration of contrast into soft lipid-rich areas of the plaque. And more, evidence of side branches, you can see here a few side branches originating from the plaque injection area, is the proof that the injection was indeed intraplaque. This is by definition, because if you are extra plaque, you cannot see side branches because you create some kind of pruning of the artery. Here the third option, which is the pattern number two. Type number two pattern denotes successful intraplaque crossing of contrast into either the distal true lumen, and this is the type 2A, or in the side branch, and this is type 2B. This is the picture I put in my paper on CCI, and basically you can see here the type 1 is due to the, I would say, the recruitment of the soft part of the plaque inside the plaque. Well, sometimes you can find some communication with the side branches, and this is the type 2B. You can see here, this is the microcatheter, this is the main branch, this is the side branch, and the type 2A is the direct visualization of the distal true lumen. The contrast trail may be absent close to the origin of the stain, as seen in these two examples, which is a typical aspect I've seen in my experience. And more, pattern number 1 and 2 can be simultaneously present. Well, I think the better thing is to show you a few cases. This is a distal RCI CTO, not so easy because there is an involvement of a bifurcation at the distal cap, as you can see. And this is what an example of pattern 1. Pattern 1, I show you, I puncture the proximal cap, I do a small injection, and look at here, this is the pattern 1 I described before, which means that I created some kind of contrast modulation of the plaque. And then you can see how they easily advance the guide wire, which is a filter FC, into the true lumen. Really easy. And no concern about the fact that there is a bifurcation over there. I wired both vessels, and this is the final result. Not so bad. And look at this case, which is very interesting. So this is an occlusion of the mid-tract of the circ. You can see here the collateral flow from the right. It's not a long occlusion. And I did a proximal cap puncture. You can see here the wire engaging the proximal cap. And look at the pattern number 2. Injection, direct visualization of the both branches of the circ. And look at, which is very interesting, I wired both branches from the same side, here and here. Very interesting, no? And look at here, this is the final result. Well, now there is another aspect I want to share with you, which are angiographic intravascular ultrasound findings associated with HDR contrast recanalization of coronary CTO, showing the intraplaque track. Well, I create a protocol for the treatment using the HDR, which is this cap puncture, HDR, which is the injection. The wire, if this is a good injection. There is the wire across the CTO. Then I do a small POBA with a small balloon in order to acquire an angiogram to confirm the intraplaque course, and also to perform IVUS for analysis and CTO plan PCI, then stent placement and final IVUS. And look at here. This is a key IVUS finding we have found. In patient where we perform this technique, we have the intraplaque guide wire crossing in all cases. IVUS evidence, this is very important, of a new sign, IVUS sign, which is suggestive of plaque modification, identified in almost 80% of cases. And this is the speckled plaque, probably with a soft plaque saturated with contrast. I show you what does it mean. Look at this occlusion. This is a RCI proximal occlusion, more than 20 millimeter long. Well, I try to, I use a Fielder XT, and it fails to cross even with a big micro catheter support. And then I puncture with a Gaia, and then I inject. And look at here. This is side branch originated before the plaque. But you can see in this the contrast modulation of the main vessel, and here in this steel frame, you can see here the staining of the plaque and the appearance of small branches here. This is a good preparation of the lesion, a good contrast modulation of the plaque. Look at how easily now the same wire as before cross the lesion, even with a bad support, you can see here. Then I inflate a small balloon 2.0, and you can see here, angio after small dilatation, you can see here, even angiographically, the intraplaque curves, because there are also side branches originating in this area. Here, you can see here. And this is the IVUS finding after HDR, okay? Look at that. This is the IVUS pullback image from the proximal cap to with the side branches originated at this level to the distal cap exiting to the true lumen, and you can see all the IVUS catheter is intraluminal at each side. And look at this very interesting aspect with this what we define speckled appearance of the plaque, which is probably here. This is a magnification of the picture, and you can see here echolucent areas within the occlusive plaque, but not proximal or distal to it. So probably we saturate the soft part of the plaque with contrast. This IVUS sign confirms intraplaque contrast tissue modification. Again, according to this picture, this is the speckled sign in this area, or according to this movie, this is the speckled sign. And look at here, angiographic findings associated with HDR. This is a RCA occlusion, which is not so easy because there are a lot of bridging collateral, as you can see. Again, I puncture the proximal cap, I inject. This is, sorry, I couldn't, to go back, how can I do? To come back, sorry. Okay, you can see here the contrast staining, this is a type 1, and there are also a type 2I, a 2B, because you can see also the distal vessel. And look at how easily the guide wire passed through. Here, there is an advancement in the side branch, and here I redirect the wire in the distal true lumen, in the main branch. Look at here, this is a small dilatation, and you see the intraplaque curves because there are all side branches preserved on the site of the occlusion. And again, even after stent implantation, the same things. Preservation of side branches, which is a very important sign. Again, another example, similar to the previous one. Look at, I puncture the proximal cap. Here I have, if I well remember, a tape type 1 pattern of the contrast modulation. You can see here the patchy appearance of the contrast. Again, look at how easily the wire passed through. And this is the intraplaque track after small dilatation. You can see very well here. And this is the final result. All side branches preserved. So in conclusion, HDR is a novel antegrade CTO crossing strategy with two essential components. Intraplaque contrast delivery through a microinjection, which must be done very gently. Use of hydrophilic wire with small tip angles. IVUS confirms plaque modification by contrast and intraplaque wire curves. And again, IVUS suggests that the HDR involved creation of new pathway for the wire passage, speckled plaque. Successful HDR is associated with high rate of intraplaque wire crossing. Intraplaque contrast delivery using microinjection is safe and does not cause excessive vessel injury. Additional study, and I hope additional China study, are needed to determine the mechanism underlying HDR. And to conclude, standard technique basically are founded so that the wire leads the way versus HDR where contrast leads the way. Thank you for your attention.